Mort. Well, it's an honor, and I must be honest, I was somewhat surprised because last year, obviously, Mort was so gracious with the panel to do the same. And of course, as he points out, we have lots of sort of things in common, Mort and I. I shall certainly enjoy reading this in my spare time, and we'll pass this on to my colleagues, of course. It's a lovely gift, an incredibly nice gesture. And I think also in that same vein, as we think about this morning's discussion, which I thoroughly enjoyed, and I hope you did too, it's very interesting to me that what I'm going to present to you now is, again, a construct that I think is very important in myeloma. And that is that as we're moving into the next generation novel agents and combinations have clearly become established, single agent activity from drugs is no longer the norm. In point of fact, obviously the HDACs exemplify that. So, of course, does elotuzumab. And what I'm going to show you is how the construct of rational, biologically informed combinations provides us with very, very key constructs going forward in what we do for combinatorial therapeutics for our patients. And I hope, as was clear in the debate this morning as well, we urgently need them, recognizing all the challenges that we addressed. We definitely are not curing our patients, and for those of us who are in the trenches 3-4 days a week in the clinic, we recognize only too well the urgent unmet medical need that still exists for our myeloma patients. So it's therefore a particular honor. Again, I'm very grateful to Mort and Ruben and the panel for selecting this abstract. It's again another example of what's been a common denominator in myeloma research, which is true teamwork. And I especially want to acknowledge that. This has been a fantastic team in the context of our Ibrutinib work. And I also especially want to acknowledge the sponsor, Pharmacyclics, who've been a delight to work with and very constructive in every way. So the abstract is basically Ibrutinib in combination with low-dose dexamethasone in patients with relapsed or relapsed refractory myeloma. And it's results from our large multi-center phase 2 trial that at the end of the day enrolled over 92 patients. I want to start by giving you mechanistic rationale for the use of Ibrutinib in myeloma. I think all of you in the audience are familiar with how this remarkable agent, through BTK inhibition, has been a game changer in CLL, and obviously some beautiful work led by my colleague Steve Trion has established it also in Waldenstrom's macroglobulinemia. So as a single agent in those diseases, and now of course in combination in CLL and so forth, it has become a very important new class of drug, and a drug in itself as a first-in-class agent. Now, in myeloma, there's a strong rationale for why it may, in fact, be something that will have activity. And it's summarized in this slide here. And it's truly a target, or a drug, rather, that targets the bone marrow microenvironmental niche. But I do want to bring to your attention its effects on cortical bone. And moreover, fascinatingly, recent data published just this year suggests that it may have a profound effect on this entity of what we consider stemness in myeloma, which we recognize as not one cell, but rather a functional process that may underpin the true sort of stem cell compartment that constitutes this residual disease component that obviously is the source of treatment failure and a barrier to cure. And I summarize that a little bit more functionally in this second slide. This is beautiful work from my colleague, Dr. Zuzu Tai, Yuzu has done a lot of beautiful work mainly in monoclonal antibodies, but actually she's done lovely work also in this BTK space. This she published a few years ago in Blood, but it really is a highly sophisticated and in-depth interrogation of the pathways that Ibrutinib or BTK inhibition subserves in the context of the myeloma microenvironment. And essentially what I'm showing you here is a functional analysis of what goes on when Ibrutinib is introduced into her model systems, and how you can see the pleiotropic effects that these pathways and this particular molecule subserve. So based upon that, and with phase 1 data in which tolerability had been demonstrated and activity at a dose had been established, our phase 2 study design sought to further evaluate the role of Ibrutinib as an oral agent administered in a dose escalation fashion across separate cohorts with or without the combination of dexamethasone. And I think basically in design, it was simply a phase 2 open-label, non-randomized, multi-cohort, multi-center trial. As I mentioned, it enrolled over 90 patients. Our primary objective was to look at clinical benefit rate, and we recognize that for drugs like this, the hard endpoint of PR or better is a difficult one. So clinical benefit rate was determined as minimal response or better, as originally defined by Joan, Blade, and the Blade criteria, and validated more recently in the IMWG work. And our secondary objectives were to look at duration of clinical benefit, to look at the harder endpoint of PR or better, the duration of objective response, and of course, safety, as well as an exploratory evaluation of pharmacokinetics. These are the patient characteristics summarized here, very typical for a relapsed refractory population in our disease. Median age is very typical for the group in the mid-60s. What I want to bring to your attention is the median number of prior therapies, which was 4. What's also true is the spectrum of cytogenetic abnormalities that we saw. Particularly want to bring to your attention in cohort 2, the high number of high-risk patients in that particular cohort. This obviously is an inevitable hazard of any kind of cohort design in this setting, but I think it exemplifies the fact that this was not a good risk population. This population of patients were heavily pretreated and had resistant disease. Now, reflective of that more is this summary of their prior treatment exposures summarized here. As you can see, the vast majority had alkylator exposure, a smaller proportion had thalidomide exposure, almost all had prior lenalidomide, all had prior bortezomib, the majority had prior transplant, and even a number of them had been exposed to pomalidomide and also to carfilzomib, recognizing that these are new and exciting new drugs on the block, but at the same time, a significant proportion of our patients had already received those therapies. Now, as we think about when we assess response rates in any patient to new drugs, it's very important to understand what their most recent therapy was, recognizing that in this particular study, the median number of prior treatments was 4. In this context, basically, as you can see, the majority of patients were unfortunately losing benefit to either immunomodulatory or proteasome inhibitor-based therapy or both. And I want to also stress that the patients also were all steroid refractory. And a majority of patients, as you can see, were relapsed and refractory, with a smaller proportion who were relapsed. So this is what really caught our eye in this large trial. The best overall response by IMWG criteria for, again, this monotherapy approach with or without the addition of dexamethasone is summarized here. As you can see in cohort 1, this is best response based upon monotherapy. You can see here that these patients we saw a signal in this group. But I think what was most striking was the response rate that we saw in this particular group, cohort 4, of an N of 43 patients, where at the maximum dose of Ibrutinib at 840 milligrams with the dexamethasone dose added. Now, in this context, for these patients, the clinical benefit rate of MR or better was 23%, and the rate of disease stabilization or better increased with dose, as illustrated by the yellow bars. So we were struck by this. I did mention that cohort 3 was particularly enriched for high risk, and perhaps not surprising in this particular group, the single agent signal was disappointing, but nonetheless a third of patients stabilized. What was then particularly striking was the following, that actually at the top dose, at the 840 milligram dose, you can see the progression-free survival in cohort 4 was striking. The median here, as you can see, is at 5.4 months, and this is certainly, in this large study, we thought compelling. What about side effects? Well, in this context, hematologic treatment emergent side effects are summarized here with a frequency of greater than 20%. And the important point to mention here is that, in fact, in terms of high-grade events, these were relatively uncommon, and hematologic toxicity was certainly considered manageable. In terms of non-hematologic treatment emergent adverse events, they're summarized here. And again, if you look specifically at cohort 4, you can see that the rate of grade 3 and 4 events was very small. And in that same context, what we predominantly saw were GI side effects as a function of the drug's known toxicities in the context of diarrhea. Other side effects included fatigue, as well as nausea, some muscle cramping, and so forth. So the safety summary is here. No significant differences were observed across all the cohorts, whilst there were a proportion of patients in this very sick group of patients who experienced grade 3 or greater events. Generally speaking, the side effect profile proved manageable. And I think the discontinuation rate points to that. In terms of other adverse events of interest, peripheral neuropathy was very uncommon. And of course, it's important to recognize that these patients had pre-existing peripheral neuropathy. Only in one patient was there some significant renal toxicity seen, and that was in the context of IV contrast administration for CT, so unlikely to be drug-related. And I always think that patient disposition always gives you a clue to the toxicity of a regimen. And as you can see here, the adverse event discontinuation rate was, I think, favorable, again, recognizing that these are relapsed refractory patients, and so in this context, particularly vulnerable to toxicity. So our conclusions are summarized here, that the safety profile was generally manageable and certainly consistent with what's been seen in CLL and Waldenstrom's. Obviously, there was no increase in toxicity observed at this higher dose, which was encouraging because certainly in that group of patients, in the cohort 4 group, MR or better was seen in 23%, with PR or better in 5%, with stabilization in approximately a third. But the real signal that struck us was the progression-free survival at 5.4 months. So whilst we fully recognize in a single-arm phase 2 trial, one has to be very cautious in interpreting this information. For a 92-patient multi-center experience, this is obviously, I think, an encouraging start. In that context, the future directions are summarized here, where we're going to continue to explore Ibrutinib in combination with other backbone agents, such as proteasome inhibitors, and in this particular case, carfilzomib. There's going to be a very nice presentation from actually Achai Chari in this regard at this meeting. Moreover, there's ongoing work now combining Ibrutinib with immunomodulatory therapy. I especially want to do a shout for the Alliance, where we're actually leading an Ibrutinib lenalidomide study led by my colleague Jacob Laubach and Yvonne Efebera from Ohio State. And I want to conclude by thanking and acknowledging our patients and their families most importantly, but all the team members for this multi-center study. Thank you very much for your kind attention.